Hello, welcome to my podcast and to my YouTube channel. Hello, Dr. Reisner. I'm very happy to be able to talk to you today. I have been listening to your interviews and reading your biography, and I'm so happy you said yes to this interview. Thank you for being with us and with my audience.
Well, it's my pleasure. Yeah.
Actually, I was just reading through all the information I have about you, so I have to shorten it. Otherwise, it would take me a few minutes to go through your biography.
That's really okay.
If there is something that you find, oh, that should not be left out, just let me know, okay?
All right.
So Dr. Reisner, he's a psychologist and a psychoanalyst, and I know that's very confusing for most people. What is the difference, right? So
Yes.
if you don't know, please Google it, because otherwise it would take us a long time to explain. But we're actually both psychoanalysts. I am as well, and I'm a counselor. He's a psychologist, so it's all mental health. Let's just say that.
Hmm.
He lives in New York, although right now he's in France. He's an expert in trauma, and this is what we're going to focus on today. He has been chief psychologist at Regent Hospital in New York City, also co-directed the International Trauma Studies program at New York University. He's a consultant to the United Nations, especially in the area of trauma. And he started his career treating suicidal patients. This is the main reason why he's here talking to us. Currently, he has a private practice in New York. Now we go to the second part of his biography, which is actually what caught my interest at first, because I listened to him in a podcast with Michael Moore. He was interviewing Dr. Steve. I'm going to call you Steven, okay?
That's
Okay,
fine.
so
Please do.
yeah, so he is a human rights advocate, and he actually is the person responsible, one of the main people responsible today for keeping psychologists outside of torture sites, because we know today that that's what happened during the Bush administration. And at the time, he was very vocal, and he wanted to make sure that this would not happen again with his profession. And we all have you to thank for this, for all the changes, because you actually took you what, 10 years to
It
accomplish
took
that?
it took us 10 years. I wasn't working alone. I was working with a
Yeah.
very dedicated group of psychologists and human rights activists. And but it was a long, hard struggle, and
Mm.
I learned a lot about long, hard struggles. And we were not lucky, we were dedicated, and things went our way. And in the end, we exposed what was going on, and we were able to make some significant changes. Um, but it was only done because we were a group, we each had our skills, we cheered each other up in the most despairing moments, and
Mm-hmm.
we were just dedicated and continued the fight
Mm-hmm.
until it would end, which were, in our case, we were lucky it ended in some significant change.
Mm-hmm. Can you tell us a little bit about that work, and what were these struggles and what was the result?
Okay. Well, as you said, it was over 10 years ago now. Actually, it's about 15 years ago at this point that um, I and some others began noticing that when the military and the CIA, American military and American CIA, were speaking about their interrogations, they would have psychologists as the spokespersons. And it turned out that psychologists were very deeply involved in interrogations for the CIA and the Department of Defense. And that seemed already, just on the face of it, an ethical problem, especially because the reports were that those interrogations were not just interrogations, they were torture. They were coercive, they were abusive. Um, and our group set about trying to figure out what was actually going on. And the more we researched, the more we found out that not only were psychologists involved, but psychologists designed the torture programs, both at the CIA and at the Department of Defense. And when this was brought to the attention of the American Psychological Association, the association did everything in their power to stop our investigation of the problem, and to and their basic attitude was to not interfere with government and military or CIA programs. And it took us years to expose, first of all, what was going on, and second of all, the collusion of the American Psychological Association in helping what was going on to keep going on.
Mhm.
Once we exposed it, with the help of some very dedicated reporters, including James Risen of the New York Times. He was a Pulitzer Prize winning reporter, and he took on the, the story. And it was exposed. The APA did a thorough self-investigation. They found that basically everything we were saying was the truth, that psychologists not only were involved, but as those same psychologists were deciding what the APA policy should be about those interrogations, and that the APA turned a blind eye to all of that. Once all of that was exposed, the APA governance and the APA leadership uh, decided to have a reckoning and to make changes. And so now, today, the APA policy is that psychologists can't even be present at places where torture is going on, where international law is being violated. So at Guantanamo, for example, you cannot find a psychologist working ethically in accordance to APA policy. If a psychologist is there, it is considered to be unethical practice. And that is a major change. And it is, and we're still fighting to make sure that the APA doesn't turn back the clock, but so far they've been pretty strong in uh, in keeping this change. Uh, but it's a matter of us making sure that that they don't that they don't turn back to the way that it was. And so we are always watching.
Yes, you have to keep watching, and we're thankful for your work and all the group that was involved, because to me it just sounds unbelievable. It's the same thing of having doctors, right, involved in this kind in torture. And I remember they didn't they had a name for it. It was enhanced in interrogation, right? Yeah,
Yes,
talk about
that's
metaphor.
what they
Yeah,
called it. Yes,
yeah,
they wanted to make it sound much
yeah.
softer than it
Hmm.
was, but the the investigations, the Senate did an investigation, and nobody will call that an enhanced interrogation. You can only call it
Torture.
physical and mental torture.
Let's give it the proper language, right? This is
Absolutely.
so important in our work.
It's
Well,
important not only
yeah.
in our work and not only for the psychologists, but the newspapers, when they were reporting on it, didn't use the word
Mm,
torture for many years. They were
wow, that's a good
they were
point. Yeah.
they were accepting the government's line that this is an enhanced interrogation, when in fact it was, according to all international law, all definitions, it was
Well, Stephen, thank you so much for your work, and do keep checking if it's ever going to change. I hope it doesn't. But let's talk about your clinical work, because that's an
torture.
extensive work too, very relevant to my audience. You
Yeah.
started your career treating suicidal patients. Can you
Yeah.
tell us a little bit about your experience? And also, I do have a question. Do you find that over time the struggles have changed?
Okay. Well, let me start with how I started in in the area of suicide, and then I can respond to the second part of the question. But
Mhm.
to begin with, so I began my work at Regent Hospital, which was a hospital that specialized in people with addiction disorders, including alcohol or substance abuse or eating disorders or chronic self-harm, self-mutilation. And that hospital, the story is that that hospital was bought by a for-profit corporation, and uh, it began some practices that I and some other staff felt were unethical, and we we decided we're going to have to leave the hospital. And I had a young family, and I needed to start a private practice kind of quickly. And when I worked in the hospital, I worked with people who were quite self-destructive and quite suicidal. And so when I shifted to a private practice, I I found that there were people that most clinicians didn't want to work with. Most clinicians were afraid of people who were suicidal. And I didn't have that fear. And, you know, it's an interesting question why I didn't have the fear of working with suicidal people. And I believe I've thought about it a lot. I'm a psychoanalyst. I also went through analysis. I kind of analyzed it. And what I've come up with is that, you know, I'm a child of survivors of the Holocaust. And my mother in particular went through some very serious horrors. She was in the Auschwitz concentration camp.
Wow.
And, but when I was young, she never spoke about it. So I grew up in a home where there was kind of the ghosts of death and the ghosts of terrible experience, but I never knew exactly what those experiences were like, what she actually went through. And eventually, it took a long time, I began asking her, and she answered me. But when I became a clinician, I found that I was kind of fearless in listening to people tell me about their experiences, no matter how bad they were, or their fantasies, or torture. I've worked with many torture survivors, and I've worked with people who have images of killing themselves and elaborate ideas of how they might do it, and elaborate ideas of what's wrong with their lives and their hopelessness. And what I found was that it was hard for clinicians to see those people. They were afraid. But I wasn't afraid. I was curious. I was really curious. I wanted to know how they got to where they were, what their feelings were really like. I didn't want them to hide it.
Mm-hmm.
And so I would speak to them about, you know, many of them in the hospital had already attempted suicide. And, you know, most of the therapists that they dealt with just wanted to cheer them up and give them hope and make everything better. And I did not find that that was going to be the therapeutic approach for me or what I thought was really best for them. So that's how I began treating suicidal people. And it was easy for me to have patients who were suicidal. I mean, to fill my practice up with suicidal people because most clinicians were afraid, and I was
Well,
not.
there still are today.
Yes, they
It
are.
hasn't changed that much, actually.
I think it's gotten worse because
You
people,
think so?
well, I started 30 years ago. Um, and in the time between then and now, I think then people were kind of afraid of what would happen to their reputation. Now people are afraid of getting sued. So in America,
Liability. Yeah,
their
liability.
liability has become, you- let's put it this way, fear of liability has replaced fear of being unethical. So when you're taught ethics as a psychologist in America, you're not taught ethics. You're taught how to avoid being sued. You're taught how to not do anything that will get you in trouble rather than not do anything that is ethically wrong.
Mm.
Even, you know, if it will get you in trouble, sometimes you have to do something that might get you sued because it's the right thing to do. And working with suicidal people, the ethical dilemmas are constant, as I'm sure you know. Um, but you don't always do the thing that is the most safe for the clinician. You sometimes have to take serious risks and go with them to, wherever their emotions lead you.
Mhm.
So it so yes, people have always been afraid to work with suicidal people and always want to cheer them up.
Can you
And
give us examples, Stephen, of these risks?
oh yeah, I mean, I'm thinking of um, uh, a man that I worked with for a number of years, many years, and he had made two very serious suicide attempts. One before I saw him when he came into the hospital, and then when I took him into my private practice, right in the beginning, he made another very serious suicide attempt. And I told him from the hospital that I would only take him back into my practice if during our therapy he gave up suicide as an option. And he just had to give it up. If he changed his mind, he could stop the therapy and he could kill himself. But if he's working with me in the work,
Mhm.
I needed to know, because it was shocking to me, his suicide attempt. It was very severe. And it was a matter of luck that he didn't die. And I just said, if in the work with me, you have to give it up. And we worked for about 4 years like that. And one day he said to me, um, I need you to end our contract. I need to have it be my choice now and still work with you, whether I kill myself or not. And I thought about it and I understood therapeutically why that was necessary for him. And a couple of weeks later, he came in and he said, I feel really bad. And I believe when I leave here and when I go home, I'm going to kill myself.
Wow.
And I said to him, I said, your life is in your hands. And he left, and I spent a sleepless night.
Wow. What scary time, huh?
But my strongest sense was that he needed to make the decision for himself. That if I called the police, if I sent him to the hospital, we would start all over. And he decided not to kill himself, and he came back. And that was a huge moment.
Shift. Yeah.
Yes, a huge shift. But, there is not a liability insurance person or an ethics teacher that would have supported my not sending him to a hospital at that moment. But therapeutically, I felt, and not only therapeutically, as far as his own dignity of his own being able to take responsibility at that moment, he was ready for that.
Hmm. Well,
So
you'd been treating him for a few years, so you know him
for
well,
4 or 5 years at
and
that
maybe
point,
how he would respond to that.
I I took a risk.
Yes. Wow.
Yeah, this is one
So
of the
going
there's
back, so
go
going
ahead.
back to, oh, sorry, going back to the question, to the second one,
Yeah,
if you find that the struggles have changed over time, and also, Stephen, if you could connect that to culture, what is the
yeah.
impact of culture on that?
Well, one of the things that we have discovered, or at least that I've understood over the years, is that suicide as a general problem and suicide as a clinical problem are not necessarily the same. And so, for example, it is known that for every percentage point that the unemployment rate in a country goes up, the suicide rate also goes up. So that suicide is not necessarily a completely psychological or irrational uh, state of mind, but a response, it's a combination of a state of mind and a response to a kind of hopelessness and helplessness, which culture can um, magnify. And then there's one more piece which has happened over the past 30 years, and that is what the role of therapy is. And more, therapy has become about relieving symptoms and seeing symptoms as the problem and making the symptoms go away rather than understanding, living with the person you're treating and helping them discover a meaningful life, a way of finding meaning in their lives. And
Mhm.
so, um, And so treating suicide purely, for example, with antidepressants or insisting that anybody who's suicidal must be on antidepressants or you're practicing, you're not practicing uh, ethically, or, you know, doing a checklist about what kind of symptoms you've had, whether you're sleeping and whether you're eating, and whether you have a plan. I find that on some level helps suicidal people postpone their suicide because they feel a little better temporarily, but they don't have hope in the therapy. They don't have hope that the doctor really understands them. Their belief is, their experience is that the doctor just wants their suicidality to go away. And so they just push it away and try to pretend that it's not there, or, to cheer themselves up. And I, I find that more and more when suicidal patients come to see me, they've already accepted that their problem is that they feel bad and that they're not supposed to feel bad and that there's something wrong. And so my first step with them now has to be to help them understand that, there's probably a world of logic to their feeling bad. And that our job is to understand what they're feeling bad about, how come they feel hopeless, and to, first of all, to normalize desperation in a desperate world. I mean, sometimes people live in a desperate world. Sometimes people have been traumatized over and over again because of circumstances that are beyond their control or that they don't know how to get out of. Trauma is a perfect example because very often the traumatic response is a kind of a normal response to a terrible circumstance. And you don't want people to feel like there's something wrong with them because they feel so bad. So I have found that our medicine more and more has moved away from normalizing bad feelings, from understanding bad feelings, and from allowing people to talk about their bad feelings. And it's moved more and more away from what is essential for suicidal people and for traumatized people. And that is a real process of mourning, a real process of understanding their losses, the sadnesses of their lives, what they feel at the moment hopeless about, to give them a chance to grieve, because very often people are suicidal because they've lost so much, and
Yeah.
and they don't feel that there's anything for them in life.
Mhm.
And you don't want those people to be given antidepressants. You want those people to understand that life is made meaningful partly by our bad experiences and by our suffering and by what we learn from that and how we can have compassion for other people who suffer based on being open to our own suffering. So I think that it's just harder now than it used to be to get people to work through their pain in a useful way.
Yes. It's even hard now to know where to start because there's so many things I want to comment on. But I'll start with normalizing because we do have, and that's where culture comes. In Brazil, I feel I'm in the US now, but I'm Brazilian. I came here for my master's. And I find that there is almost fear of emotions in
Mm,
this culture. I think for that's my perspective as a Brazilian. We are more open to talk about our emotions, the good ones, the bad. We don't even classify them as good or bad. They're emotions, and we're very open and we talk a lot. This is a Latin thing, and I find that I remember you were talking about normalizing, and especially for trauma. I'm thinking about a patient I had, and I was talking to her, and one time she was talking about her childhood. She was extremely neglected as a child.
mm,
Her mother had very extensive and long-term mental health problems. So she was very neglected, and she was talking to me and telling me about this. And she actually said, "Oh, I'm so sorry. I talk about trauma, but that's not really trauma." And I just stopped her, and I gave her permission to call it trauma. And I explained to her what neglect is, and I just did some psychoeducation, and in the relief that she felt
yeah.
because she could call it trauma. In the next session, the first thing she said was, "Paula, thank you so much for letting me use the word."
Yes. Oh yeah, because
Wow.
if you don't call it trauma, if you don't feel that you can call it what it is, children, especially children of parents with mental health struggles, those
Hmm.
children, that they have parents who are one moment they're very, attentive, and one moment they're in another world, and the child tends to blame themselves, for when they're punished, or when the parent gets angry, or when the parent seems, strange, and because it's the only control they have is to blame themselves, and so very often they don't want to believe that they had it hard, that they were traumatized, that they were abused or neglected. They believe that they were bad,
Hmm.
and
Yeah, they
they're
caused
so,
it
that they
somehow.
caused it, and that they are
Yeah.
so ashamed of that. And explaining what neglect is and what abuse is, and explaining, I spend a lot of time explaining how their parents' mind is working. I explain mental illness, especially severe mental illness, so that, and they begin to recognize it. Oh, she never was able to understand my point of view. She only looked at me as causing her problems. And then I can explain, what kind of problem that is in the mother, and what her mother's limitations were, and that it's not your fault. It's really the limitation of your mother. And that helps a lot for people to be relieved of the amount of self-hate and shame that they carry around.
Hmm. Yeah. Well, now let's talk about the moment we're living, right? These are hard times, harder than most of us have. Well, not you, but for me, and I look around at my friends and my family. We have never experienced something like this. I've had losses in my life, but this, I think, in a way, the change for me, what's different about what we're living is the uncertainty. It's actually building up every day. One day we know something, the next day, well, it's not really that. One day this is safe, next day, no. And especially when I think about relationships. Now relationships are our source of fear, right? You see your family and you're afraid to get close. So how does all of this fit into mental health? What have you been seeing?
Well, I there's so many avenues to begin to answer that
Mm-hmm.
question. From the simplest, I read an article about babies in intensive care. So, there are babies that are born with problems and they go to the neonatal intensive care unit. And um, during the COVID, intensive care units have been extremely protected and isolated. And so those babies don't have as much touch as they used to have. And the nurses and the parents that that take care of them are wearing masks. And the idea of trying to help a baby develop without being able to see the facial expressions of those taking care of that baby from a psychological point of view, that is an
Wow. I
extremely
hadn't
damaging.
thought of that. Wow.
Right. And I think that people are so afraid of COVID that, and I think that the press plays up the fears because what they do is publicize every doubt, every exceptional case. So if one young person dies, that's the front page of the newspaper. So everybody is afraid because it's an unknown thing. And in two countries in particular, there's the leadership is very narcissistic and not uh, communicating uh, what the truth is and what the science teaches us. And those two countries are Brazil and America.
I know us,
Yeah,
me and you
yeah.
specifically. Oh my
And so
God.
what you have is, what happens with narcissists, and I think we have in America developed a kind of narcissistic culture, but narcissists either experience themselves as immune to everything, that no, they will never die, they're all powerful, or there are threats, the threats all come from outside and they have to be stopped and blamed. And in America, you have both of those. You have, the president saying, I'm not going to wear a mask, the president's followers saying, you can't make us wear masks, we need the freedom, there's no threat. And then you have the opposite extreme where everybody is holed up in their homes, so afraid that anybody who has the illness, let's say in a nursing home or in a hospital, isn't allowed visitors. So people who've been dying in nursing homes or in hospitals die alone. They don't know, they're not allowed to see their families. It's so extreme, one extreme or the other. And I have done a lot of research because I have to deal with my patients who are very anxious in the same way you're describing. So I've done an enormous amount of research on what is the ethical way to address this uh, pandemic. And I have found very little practice in my country and your country that is ethical, because the ethical way would be to treat people who are very vulnerable differently from people who are less vulnerable. So in America, you had the opposite. In America, you it, the most vulnerable people, it turns out, were people of color,
Mm.
especially poor people of color. They were the most vulnerable because of bad health care in America, they tended to have underlying uh, illnesses or vulnerabilities. Their history of their diets made them more susceptible to things like diabetes and heart disease. They lived in the most polluted areas in the country, so their lungs, were more likely to be compromised. But nonetheless, those people were much more likely to be considered essential workers and to be forced to go to work as healthcare workers, cashiers in supermarkets, uh, sanitation people. Those very people who were poor, who lived with many members of the family, so they lived with the elderly, they had underlying conditions, so they were more susceptible. Those people ended up being forced to go to work because if they stayed
Mm-hmm.
home, they wouldn't get any unemployment insurance because they were essential workers. And so And the ones who were actually much less likely to have a severe reaction in America, which are uh, people without underlying conditions, people who are healthier, people who have more money, people who were working jobs that paid more. And those are the ones who could stay home and work from home. And the number of the difference in who was more likely to die from COVID is extraordinary. So people who are of color and have underlying conditions um, are like between 3 to 6 times more likely to be hospitalized or to die of COVID as people who do not have underlying conditions. I mean, I looked at the numbers, and out of the first 71,000 people who died in America, less than 600 had, of those were people without underlying conditions under the age of 70. Think of that.
Wow.
The number was so small. And yet, those are the people, when we talk to our patients, who are the most frightened. And they say, well, but I might infect, my family member. And that's true. So don't visit your elderly family member. But you should be at the cashier. You should be, more
Mm.
likely to be in the, taking care of our society, and let the people who are really vulnerable stay home. That's the ethical approach. We don't
Yeah.
do anything like that.
Yeah, that
So
should
what
be the policy, right? When you talk
that should
about
be the leadership.
government.
That should be the
Yeah.
policy. But
Yeah.
instead, we had people who were very vulnerable were not taken care of and had to work, and people who were stayed at home, um, predominantly middle class, upper class people, predominantly white people, they were incredibly frightened. And they were the ones who were always blaming others, and they're so afraid that somebody's going to come and sneeze on them or whatever. And they're angry and they're frightened. And I work very hard to teach them that they don't have to be so frightened. They have to be careful. They should wear a mask when they go inside a store. The illness doesn't get communicated very well in the street, but it does in stores. And they can take care of themselves. They don't have to be so frightened. But they shouldn't, be visiting a sick relative if they've been on the street, and they should be taking care of their sick relatives. But if they have an older relative who already has the illness, I think that it is a terrible thing to not visit them in their old age home or in their hospital if they're dying or they're seriously ill. They need to be visited because the research shows that if you have, if you're visited by your loved ones, you're much more optimistic, and you have much less intensive care unit psychosis or hospital psychosis. You need to be grounded in love. And
Mm.
so, my recommendation is that a family member who is not likely to have serious complications, who's young and healthy, should visit them and, wear a protective gown
Yeah.
and
Hmm.
whatever, but should visit them. And the rules against visitors, I think, are inhumane. So I wish that we were having a real conversation about what the real risks are, who's really at risk, who's much less at risk, and how we can weigh our actions based on what is genuinely the risks, and not all be terrified of this new virus as if it's the Black Death.
Hmm. Yeah. Steve, you understand trauma like not many people.
Yeah.
What kind of trauma do you think that this pandemic will leave behind? Because I was listening, but that was like 2 months ago, to Van der Kolk. He was talking about, oh, we are in pre-traumatic times, but I think that's over. I mean, I think trauma is already settling in. So what
Well,
kind
yeah,
of trauma do you think this will create or leave behind, the trail
right.
behind? Yeah.
Well, I think that I find that trauma, I said this earlier, trauma ends up being the result of people not mourning. So I think that this pandemic will be terrible, sad, mournful for people who have lost loved ones, especially people who have lost loved ones who were forced to go to work or didn't have health insurance or were afraid to go to the doctor because they couldn't afford it. And people who, you know, died for social reasons, not for necessarily because of the virus ultimately itself, but could have avoided it or been helped. There's a lot of mourning that needs to happen here. So I think that people will be traumatized if they don't understand, if they don't learn, if they don't find meaning, and if they don't demand change based on the lessons of this pandemic. And so we look at, so we will be traumatized if we think, oh my God, there's nothing that anybody could possibly have done or can do. You know, the environment is changing and we can't cope with it. We're all going to die. That's traumatizing.
No hope.
However, that's hopeless, helpless,
Mhm.
traumatizing. However, if people understand that we suffered much worse outcomes because of social injustice, because of the corporate greed and capitalism, because insurance companies demand profit rather uh, than put together a vaccination that they can't make much money on, because uh, poor people don't get health care, because uh, we didn't decide who should stay home and be protected and who can go out safely or more safely. We need to mourn this experience, but we also need to act to make change. I believe very strongly that the protests that are erupting all over the world right now, especially in America, but in many countries, are a direct result of the Black community saying that we suffered under COVID. One in 2000, think of this, 1 in 2,000 Black people in America died of COVID.
Wow, I didn't know that the number was. I know that they have 2.5 more a chance of catching the
Yes,
virus.
1 in 2,000 Black people in America died of COVID. One in
Wow.
700 Native American people died of COVID on reservations in Arizona and some of the southwestern states. The numbers are outrageously over represented, and that coupled with police abuse, that coupled with the fact that when they started having laws about wearing masks in public in New York, 80% of the arrests for not wearing a mask were of people of color. The, this just shows the injustice, and the protests, the Black Lives Matter protests in America, to me, are a sign of making meaning out of suffering. That
Mhm.
we're not going to be traumatized. We're going to mourn our losses and demand change for the future. We're going to learn from this. And I think that there's so much to learn from this pandemic. Many cities where people couldn't breathe because of the pollution the skies are clear because
Mm.
planes aren't flying, buses aren't running, cars aren't driving, um, and the change to the planet is noticeable for many, many people. So we have a change to the planet. We have a demand that people should have healthcare as a right, not as somebody's gift, especially when in America you only have healthcare if you're working, and the unemployment rate skyrocketed. So people lost their healthcare in the middle of a pandemic. And so there's so many lessons here that we can learn. and make meaningful, so that hopefully we demand of government a kind of justice and a kind of equality and a kind of caring for people not to lose their homes, not to lose their health care, not to lose their income because of of an emergency. Government, that's what, if government is for anything, it's to
That's
guarantee.
what it's for, right?
That's
To
what government is
guarantee.
for. It's to guarantee that when things are terrible, which doesn't happen that often, but when it does, there's a safety net. And that's what insurance is supposed to be about. Everybody pays a little. Taxes are a kind of insurance. Everybody pays some in order that we have traffic lights, in order that we have health care, in order that the poor are not on the street. America has completely lost that idea. The homeless population has skyrocketed. People are in debt because they go to school, because they go to for an education. Kids, young people are in huge amounts of debt, and the most bankruptcies that happen in America happen because of a healthcare crisis,
Mm-hmm.
a medical crisis. So I think that we can be traumatized if we don't change anything. And then COVID showed all the weaknesses of our society and showed us that there's nothing to be done. That's trauma.
Mm-hmm.
But if we get out on the streets and if
And
we vote
mobilize.
and
Yeah.
if we mobilize, we can avoid trauma by learning from this experience and making change.
Mm-hmm. That's a great point. I want to hear your view on which, to me, also talking about, still talking about the pandemic, but I think one of the good things that the pandemic did was to put a spotlight on isolation. So everyone now talks about being isolated, right? Headlines every day. Oh, what is isolation? How does it affect you? Oh, the relationship between being isolated and sudden death or early death. And I think that's a positive outcome of the pandemic because as clinicians, and I want to hear your view on this, we know that this is not because of pandemic. Pandemic just put a spotlight on it. We are becoming over the years and decades more isolated than ever. We see that in our patients. Most of them, what they bring into the clinic is relationship problems.
That's right.
They're alone, they feel alone. And when we talk about suicide, I'm just thinking about what Edwin Schneidman used to say. It's two main problems. One is the pain they're feeling, the other one is being alone with the pain.
Yeah.
So isolation is not new. I want to hear your view on that. But
Yes,
at least now and that's the good thing, at least now we're thinking about it. We're
I agree
discussing
with
this.
you. I would say that most of the demand for therapy that has come from the pandemic is for couples therapy and family therapy, because it's so true that people in families are increasingly isolated and they get their identity from their work, not from their leisure time, not from their family time. In in America, both parents at work most of the time. Children have enormous amounts of schoolwork. This is pre-pandemic, um, and the 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 idea of a family sitting down together and actually understanding each other and paying attention to each other's feelings and joys and sadnesses has become less and less and less and less. And what the pandemic did was force everybody to be together, and they discovered how little they really connected to each other. And I would say that there's the sadness of being alone. There's the sadness, there's the isolation, not feeling connected. But I would say there's one more piece, and that's also very difficult, and that is the anger. That people are angry at their spouses or their partners or their children or their parents for not taking the time to work through the relationship and the emotions. And there are two kinds of suicide. There's the suicide that comes from sadness and hopelessness, and there's also the suicide that is aimed at another person, that is an aggression toward the other person turned against the self. I'm hurting myself. I want you to notice it, but really, I want you to feel my pain, or I want you to feel pain so you know what I feel. And
Mhm.
that's very hard for people to talk about with each other when there's not trust, when there's not a, a, an environment of learning to communicate and of learning to be together. And that takes practice, and it takes dedication, and it takes leisure time. It takes time when families can be together without pressure. And those were in short supply before the pandemic. And now it's so complicated when people are cooped up at home. Children have to have somebody help them with their schoolwork. Uh, Parents have to do their work from home. It's so complicated,
Mhm.
and and so the stress has gotten very extreme, and the ways of coping have not been offered. I mean, people don't. Well, we need sort of classes. We need opportunities. We need examples of good relationships, of people knowing how to talk to each other, not just by getting a professional. We need other ways, cultural ways. Television. When I was a child, television was always about there's a problem, and you go to the parents, and the parents would talk it over with you. Father knows best. Leave it to Beaver. These shows that were like
Mhm.
such a fantasy of what families were like. But still, the TV shows and movies were about a problem and a kind of a value that you applied to how to deal with the problem. In the last 10, 20 years, most TV shows are about antiheroes who are, who and they're sort of the more evil that they can be, the more aggressive that they can be, the more gossipy or mean that they can be, the more popular the show is. And it's a very different sense, a very much more selfish sense rather than values-based sense. Now, I'm not claiming that the 50s was a great time in America. It really was not. But I'm interested in the idea of how we communicate values so that we can, turn to the value of honest communication and love and dealing with conflicts rather than avoiding conflicts.
Mhm.
Those values, we need a way to reintroduce that.
Yeah. And the other side of that, because you talked about families that are now together and having to rebuild their relationships. But there's also the person who is really isolated. I mean, they live by themselves, and now they're realizing that they didn't build those relationships before the pandemic. So but it's again, I see it with optimism because it's a great opportunity for you to reevaluate your life,
Yeah.
right?
Well, the ones that we see are the ones who are in therapy. And what I find with people who are very isolated, who come to therapy, is that therapy is that place to practice, discovery of deeper feelings and being willing to share those deeper feelings, even shameful ones or confused feelings or awkwardness. You know, I, people who are socially awkward. I was thinking about myself when I was younger, and I was very socially awkward when I was younger. And I was lucky. I went into the theater and I learned how to overcome my social awkwardness through the theater, and that was my practice. But a therapeutic relationship or sometimes finding social things, it's harder now. I mean, it's much harder now for somebody to take that next step and go to a group therapy or to join a meetup or a hiking club or something like that. Now that's gotten a little bit harder, introduce people who are socially isolated into the social world. But that's our effort. That's what we work toward.
Mhm. Well, you mentioned theater. I want to end this interview because this is another part. As I said in the beginning, your biography is way too long for one podcast. So, but I want to end to hear about your experience with movies and also
Mm,
your podcast, which I absolutely love. I have to say, I love your podcast because you manage to you start. It's like sewing. You start with this topic and then you wow, he's gonna change it completely. No, but at the end you just put it all together. I think it's genius the way you do your podcast. So
wow.
please talk
Thank you
about
so
that so
much.
my listeners can check it out. It's amazing and it's really unique. I listen to a
Well,
lot of podcasts and yours is unique. So let's hear about that.
it's called Madness, uh, where psychology and capitalism collide. That's, I mean, if you look it up, it's called Madness, the podcast. And I chose the title Madness because I believe that what is very often considered mental health issues are reactions, are ways of protesting, are ways of reacting to injustice, to trauma, to social difficulties, and that sometimes madness is really about getting mad and justifiably mad, and that we need to listen to symptoms and we need to listen to these issues. We need to completely understand them rather than just want them to go away. And I think that a lot of the issues that make us angry is that psychology has given up on finding meaning and mobilizing people to be socially active. And so when you go to a psychologist and you say, I am so overworked, I am so tense, I don't know if I'm going to be able to do my job, I might lose my job, my boss is unhappy with me, and I really don't know where to turn. I'm working 12 hours a day as it is. A therapist in America these days will most likely say, well, you could try meditation, you could do self-care, you could do breathing exercises, take a walk, and maybe take an anti-anxiety medication. They won't say, have you spoken to other workers, or are you thinking about joining a union or organizing a union? What is where will you find your power position? And maybe you should find, if you can, another job, or maybe you need to organize your coworkers, and we need to have a different consciousness about what's going on in our society. That kind of um, including social justice and social action and mobilization as a necessary part of thinking psychologically. That is part of what my podcast is about. I also bring a kind of psychoanalytic approach to cultural issues.
Hmm.
And yes, I do weave ideas, and
Yeah.
that's why I don't have so many episodes because
I know, every time I listen to your episode, I go, oh my God, how many hours did it take him?
it takes a long time, actually. I work and work
But
and
it's
work.
brilliant. But that's what's brilliant about it. That's what makes
Well,
it
thank you.
I love it. And I've listened to some of the episode more than once.
Well, I really appreciate it, and I hope your listeners will listen, and I hope that they'll share it, and I hope that they will write a review, because I think I have, as you said, I think I have a unique voice. I think that there's that my political voice, which includes finding a certain kind uh, of meaning in being a human being and sharing being a human being with other people. I bring in some philosophy and a lot of psychoanalysis, a lot of the idea that being a human being is all about meaning rather than sheer power. And I
Yes.
want people to cultivate that idea that power should always be used in the service of love, meaningful relations, beauty, something that makes our time on earth, our brief time on earth, worthwhile, not only for ourselves, but for others and for the whole planet. So yes, that is the point of view. And if people will listen, I would love that. And I would love for them to, let me know,
Yes,
contact
I'll
me.
make sure I have it on my notes too, a link to your podcast. But the other thing that I admire in the work you do with the podcast is that you go against the tide in terms of, as a psychologist and psychoanalyst, you don't pathologize human responses, natural human responses.
Yeah.
And that's so important. I know, because we see it in our patients all the time. I've had patients that, first session, you ask them, okay, tell me something about yourself. Tell me what brought you here. The first thing they do is they describe their symptoms and what medications they've been taking. And it's like their whole identity is glued to a disease. And I think it's
Yeah.
so important for people like you to say, no, you know what, you are anxious because this is what's going on in your life. I would be really worried about you if you weren't. It's like now in the pandemic, right? People are saying, but there's something wrong with me, I can't do anything. It's, of course you can't. I mean, look at
Right.
what's happening to the world. It's not even just you, right? So
Yes. And I
it's
can
so
tell,
hard, and it's so hard
yeah,
for people to understand that it's not a disease. You are absolutely normal.
I can tell the listeners that I didn't do a podcast episode for 2 months during the pandemic. That the level of of dislocation and strangeness
Mhm.
was affected me too. I couldn't concentrate, and and so yes, it is very important for people to understand where they're coming from and not just label it. But the other thing that I try to do is that I think that a lot of pathologizing is defensive. It gives us an easy answer to a very difficult problem. And so in the last episode, I talk about Trump, and I talk about how everybody loves to diagnose Trump as a narcissist and a sociopath, and they want to say, see, he's pathological, so he shouldn't be president. And I talk a lot about what I think is Trump's psychology, but not from a pathological point of view. I mean, narcissism and sociopathy, I say, are in 21st century America, especially corporate America. These are not diagnoses, these are strategies for success.
For success, exactly.
Yes, you can, if you're a corporate CEO, if you're a politician, if you don't have if you don't have narcissism as a politician, and if you don't have sociopathy as a CEO of a major corporation, you will not be a success. And Trump has plenty of both and uses it for power. And that's where the problem is. It's purely for his executing his own power and personal
Mhm.
benefit. That's
Mhm.
the problem. That's not diagnosable. That's evil.
Mhm. Wow. Well, thank you for your words, for your knowledge, and for sharing. And it's so late. I know, what time is it there now?
It's
11?
after 11 at night.
11
Yes.
p.m. because he's in
Yes.
France. Well, stay safe. And thank
Thank
you so
you.
much for your time. It's
You
been
too.
lovely.
It's been a pleasure. It's so nice to meet you and to share
Thank you.
this. Really, it's really been a pleasure.